First of all, thank you for coming, and I'm glad to be here. Susan gave me the charge to speak as a clinician and how we see these things on a daily basis. And I just want to say regarding Gary's work at the NIH, it's truly incredibly important stuff. And we, myself personally, have been heavily involved with GenTAC and the Clinical Trials Network for cardiac surgery, and both of them have been incredible studies. And I just want to congratulate you on making that possible. A lot of important questions regarding heart valve disease were answered by both those studies, or both those long-term trials. So what is the clinical state of heart valve disease? This is going to be a little bit of a TED Talk with mostly just lots of pictures and not a whole lot of data, so it's kind of the opposite of what we do at the meetings. But the first, as you can see, there's 4 heart valves, but really there are only 2 important heart valves, especially in adults. There's the right side of heart valve is very important in congenital heart surgery, but in adults there's really the aortic valve, which is right in the middle of the heart, and then the mitral valve, which is actually in the back of the heart. And you can see that there's 2 atrioventricular valves that are kind of similar looking, and 2 semilunar valves, and this is about how we're made in utero. This is a picture, and it was supposed to run. I don't know if it's, yeah, there it is, starting. This is a pretty old computer. I hope I can run through these megabytes through this processor. What you want to see in this picture, if I can get the, oh, there we go, is that this is an echocardiogram looking at kind of the heart working in real life, so to speak. This is the aortic valve. It's pretty normal aortic valve. This is the atrium, this is the aorta, here's the main pumping chamber, and here's the mitral valve. What you can see is that these valves kind of work together. They're a little bit connected in a certain extent, right about here. And in this case, which we'll talk about a little later, the mitral valve is leaking very significantly. The whole point of this slide, though, is that we can get very, very good images and understand pretty much what's going on with the heart from high-level echocardiography. Now, I thought you'd like to do a picture of that Mercedes sign we were just talking about. It's very rare in a live human being for us to actually get a picture of a very perfectly normal aortic valve. So, if you go to the cadaver lab, you can do it, but that's not quite the same. Because we never really operate on normal valves. We don't really see them. So, but this is the case where there's an aneurysm as a primary problem, and we want to save these aortic valves. So the only point was to show you exactly what these things look like. They're very thin, beautiful leaflets. There's your Mercedes sign. We're saving this valve, and we're kind of creating an aortic root around it, but that's irrelevant to this picture. And what you see is a nice coaptation zone of these 3 leaflets in this aortic valve, and that's kind of what we want to, that's normal, and this is what we want to keep and see. Now, the first condition that's important is aortic stenosis. So this is the most common, this is the second most common condition, but it's probably one of the more important conditions, which is aortic stenosis. This is a calcified valve. Remember that one I just showed you back there? Keep on referring that in your head. And this is a bicuspid aortic valve, actually, and it's extremely calcified. It's a piece of rock. It's Mount Rushmore, this is not working very well. It's got a slit here for an opening, and this patient had a serious issue. This is one I took out a couple days ago, and you can see this calcified aortic valve, we took it all out and put a brand new valve in. So the cause is, as Gary was talking about, is the buildup of calcium on the leaflets, restricting their mobility. One of the big things at the NIH and investigation level is to try to cut this or modify this early on, which is what he was talking about. You get thickening of leaflets due to the disease. Radiation also causes this. And the risk factors are mostly age. Diabetes is a risk factor, especially regarding acceleration of valve disease. So if you have it, it's going to progress a lot faster if you have diabetes. Rheumatic fever, not so much in this country, but especially in kind of second and third world countries. Smoking, and we just talked about bicuspid valve. Bicuspid valve is actually, I think, in the last 10 years become a lot more understood and is probably a very important thing. The most important thing about bicuspid aortic valve is that 1 out of every 100 or 200 people in the United States will have a bicuspid aortic valve. So as a Philadelphia Eagles fan, if you go to the link for an Eagles game, there's going to be about 300 people in the stands with bicuspid aortic valve. And most of those patients will end up having an operation or significant symptoms between the ages of 40 and 65, so it's kind of prime time. So it's a very important thing. It's not all about the aged, okay? And it's not all about the babies either.
Right.
This is that one spot in the middle that's actually pretty important. I bet you there might even be somebody in this room with a bicuspid aortic valve. Who are you? So this is a normal aortic valve on echo, and you can see nice thin leaflets, no turbulence as Gary was talking about, and then you see this is an aortic valve that's calcified and rigid. It's not moving very well, and this is what aortic stenosis looks like on the echocardiogram, tight aortic valve. Now the bicuspid aortic valves look like this. They're somewhat gnarly as time goes on. This is a what we call a true bicuspid aortic valve. This is a 180-180 bicuspid aortic valve. This is a symmetric aortic valve, and symmetric aortic valves tend to be a little bit better. The flow patterns and the turbulence across the valves are a little less because it's symmetric, but it is quite an abnormal valve. More importantly, and much more common, is what we call the asymmetric aortic valves, bicuspid aortic valves, where you have this in utero, as Gary was saying, they're not quite getting to that Mercedes sign. The embryology is such that they're trying to, so to speak, but they ended up having this kind of raphe, we call it, or partial commissure. So there's only two real commissures, but there's that third one just doesn't form and it fuses together. And that's a very abnormal flow pattern. And these are the valves that get thick, get calcified, they leak, they're tight, they're both, and they usually present pretty early in life, about in your between 40 and 65. So bicuspid aortic valve anatomy, important thing. And this is an example. This video was too big to play, but this is a typical bicuspid aortic valve in a young woman. This was a 30-year-old woman, and she had this bicuspid aortic valve, and you can see this torrential leak here. There's none of that's supposed to be there on an echocardiogram. So this is actually what I call a +5 leak, which is higher than the highest.
Wow.
So this is a leaking aortic valve, not a tight aortic valve. So aortic regurgitation, which is a leaky aortic valve that causes our aortic root aneurysm. So so sometimes it's not really the valve that's the problem, it's more the aorta. We're going to talk about that with the mitral valve as well. There are what we call primary conditions in the valves and secondary conditions in the valve. Primary conditions are about the leaflets. Secondary conditions are about the surrounding parts of the heart or the aorta that cause the valve to physiologically be bad, but maybe not anatomically that bad. Leaflet damage, especially endocarditis, we see primary leaflet damage, and leaflet prolapse, like I showed you earlier, which is an asymmetric valve presentation and causing problems that way. This is a picture of endocarditis. Most endocarditis today is related to drugs, IV drug abuse, or it's from the mouth. As you know, human beings, or maybe you don't know, but human beings it's worse to have a human bite than a dog bite, and so from the dentist and other bad oral dentition, if you have problems there, you can get infections in the valve, and that's where most of them come from. And this is what that looks like. You get these destructive holes in the valves, and these big vegetations look like cauliflower or broccoli, and much in medicine is described by the pathologists who have this vivid imagination, and they're all foodies. This is a valve that is bad or abnormal with a big leak because of an aneurysm. So here's an aorta here, and you see this large aneurysm. This is actually only a 30-year-old young man, and you have a large aneurysm here, and you can see that this valve just isn't able to open, isn't able to close because it's so stretched, and this is what you see from an aneurysm kind of case. Now the mitral valve is a very important valve. So the aortic valve and the mitral valve are the most important valves. The mitral valve is the inflow valve of the heart. The aortic valve is the outflow valve of the heart. Okay, it's like pump 101. You cannot function, the pump can't function very well unless you have a normally functioning inflow and outflow valve. And as Gary said, this is the high pressure chamber. This is the chamber that has 6 times more load than the right side. So the right side is not that important in adults anyway compared to the left side. So the mitral valve is a hugely important valve. What happens here is you get this valve, this mitral valve, which is a parachute concept, okay? It has cords, it has two packs, just like a parachute guy, and all these cords coming down from the leaflets, and the leaflets open up, which actually means they're closed to air, closed to blood, and that's how this thing works every second in your body. It's opening up, and it stops because of these cords. And just like a parachute guy, what jumps out of an airplane, if those cords aren't intact, you got a big problem, okay? So in this case, what happens, you get a big leak, or if the heart gets enlarged, which happens from a lot of different cardiac diseases, the valve, which is perfectly normal leaflet structures, gets leaky because it just can't close, because everything's too stretched out. And this is what happens when you have heart failure as the primary. So we get a little bit of chicken and an egg here. Many times the valve causes heart failure.
Right.
But a lot of times heart failure causes the valve disease. So it goes both ways. And that's why diagnosis and imaging are so important to figure that out. And doctors, good doctors. So here's what happens here. You've got a large heart and it's stretching the valve, and the valve just simply can't close. And this is mitral valve regurgitation, which actually is the most common valvular lesion of all, is mitral valve regurgitation, even more common than aortic stenosis. It's not treated as much with surgery or replacement, and it's treated mostly medically, but it is the most common one. And this is the same picture, but just to show this exactly what I just said. This is a severe leak of the mitral valve. There's not supposed to be any of that mosaic, and this is a mitral valve that's stretched out and not closing, and this causes an extreme inefficiency on the pumping mechanism. Okay, and eventually this causes heart failure to a very significant degree. Now this is a mitral valve regurgitation, looking at the imaging, which is the opposite problem. So this is a pretty good heart. Not a bad aortic valve here, but what you can see here, if you look at the mitral valve leaflet, is that, as I just said about the parachute guy, the cords are snapped. So this is what happens when the mitral valve does not have its chordal structures, and you get this leaflet that's kind of flailing up into the heart and kind of all over the place. Okay, and you can see what happened here. You get this big leak, which is an eccentric leak, swirling around in the heart chambers, and this gets into what Gary was talking about. This is it's a new imaging we have, which is these 3D echoes. We even have 4D echoes. That's one of the things he showed. This is very good imaging that shows us a lot of stuff that we can figure out. Can we repair the valve? Can we not repair the valve? Exactly what the anatomy of the leak is. What's the physiology of the leak? It's pretty amazing. This is a 3D echo of the same one. So other causes of heart valve disease, besides the two big ones I've said, which is the aortic valve and the mitral valve, and primary and secondary lesions, is congenital heart disease. Now, most of the time, congenital heart disease, as we're saying, is on the pulmonary side. Not all the time, but a lot of the times, which is the pumping chamber that pumps through the lungs. And this is an example of pulmonary stenosis. There's tons of examples. I don't need to go through all of them, but this is and they're actually all related in a continuum of congenital heart defects. That's kind of the Norwood approach to life. But the pulmonary stenosis is one of them. It's in a you might have heard of tetralogy of flow. It's in that category. Another reason for aortic valve disease in a secondary area is a catastrophe known as aortic dissection. So when you have an aortic dissection, what happens is, which is a hypertensive problem or a problem with your aortic wall primarily, which is like one of the conditions such as Marfan's or even bicuspid aortic valve, where the aorta is the problem, and it basically delaminates, okay, and it becomes a baklava, okay, and you end up getting these, the whole aortic wall delaminates, and this is a disaster, and a lot of times it's lethal, but when we get to it, we can actually repair these valves because they completely lose their ability to stay functional, because they don't have any mooring, they don't have any place to attach to. But we can repair these in the operating room and create a normal valve function from this. So it's pretty interesting. So this is another aortic valve presentation that's not quite in the frontal lobes of most everybody out there. Mitral valve stenosis is actually not that common in the U.S. It's not that common in first world countries such as Europe or Australia or other places, Japan, but it's actually really common in the world. Okay? In fact, it may be the most common lesion in the entire world. In the U.S. at this point, most of the patients that I operate on for mitral valve stenosis are from Eastern Europe, from Russia, primary immigrants, or primary immigrants from Jamaica or from some of the Caribbean nations, or from Latin America, or from Africa, and also Thailand and Cambodia and Vietnam. So those places, there's still lots of rheumatic disease, but not in the first world countries. But it does require replacement because the valve gets tight, it gets completely calcified and thick, so you can imagine it's like a big dam inside the heart. It's a big problem. Symptoms and natural history. This was Susan went over this real quick, but most of it is all the symptoms of heart failure. So fatigue, shortness of breath, etc. But the final common pathway that one must always remember is that it's heart failure. It gets into the symptoms of heart failure. One of the things that we've done, this is the only kind of a slide I'm showing that's medical, is that over the last 40 years or so, we've actually done very well and have improved our medical management of valve disease during the period prior to any intervention. This is from Ross and Bruno in the late 60s, and it shows that valvular heart disease is kind of interesting. It has this long latent period where medical management is kind of hanging out and not that bad, and what it really is a testament to our ability as human beings to compensate for problems. Okay, we're built with redundancy, and that's what this latent period is. And then what happens is the wheels fall off the cart. Okay, as soon as you start getting symptoms, you go from 0 to 60, which is dead, pretty fast. And so what we've done over the past 40 years is not change this paradigm that much, but we've extended the latent period substantially. And so this is the 2015 latent period is extended, and this is from Bob Bono from Northwestern and the ACC. And but we still have the same bend. And the key to timing of these, and this gets into awareness and referral patterns and educating not only patients and in the population, but also family doctors. And what we want to do is we want to operate or intervene right in here before the curve, but at the very end of the latent period. Now I wanted to show this picture here. This is from the operating room. Is that, again, this is symptoms. So this is a really leaky aortic valve. Okay, so this is kind of this is a picture into the sanctuary. Okay, and the fact of the matter is that this is what's called a water hammer pulse. So all the medical students know about this, and it's when you have a really leaky valve and your whole body starts pulsating. Okay, and you can see this dramatically in this picture. And this guy had like the worst aortic valve insufficiency you can get, and you can see that he's just boom. And if you were to put a finger on his pulse, it would just jump out at you. This slide was shown by Gary, so I don't want to go into it anymore, but the bottom line is that if you look at all heart valve disease, especially as we age, which is one of the reasons why we're here, it's going to be represented somewhere in 10 to 14% of the population at between 65 or 75. What is interesting to me, and this may be the bicuspid situation, is that it starts to take off at about 55, and so you wonder why that cusp is right there. And I think this is where most of the bicuspids are just starting to. That's the first valvular heart disease that's present in human population. The other thing is that from the population studies is that I think there's a great awareness or not aware, especially in the aging populations, that if you're 65 or 70, you have a long time to live in this country. Okay, and this is from the 2005 data. The 2015 data from the 2010 census is even better than this. I think for 70, it's up to like 17.9 years now. So in other words, if you make it to 70, you have a long time to live, and we need to know that. So we can't have any age discrimination regarding treatment. That's the big thing. Its cost. Bottom line is, this was also shown a little bit earlier. The cost to taxpayers of having valve disease is about $10,000 per patient, extra over what the normal person would be. So it is a problem, not just clinically, but also from a standpoint of policy and money. Treatment options, real quickly. The first one is the aortic valve replacement. This is a typical tissue aortic valve. What we do is we open up the aorta, open up the chest, and this patient put in a new aortic valve, take out the old one, size it up just right, and it's a nice operation. Here's another typical valve from two different companies, but they tissue. These are bovine tissue valves. From the STS national database of over 100,000 patients, it's up to over 250,000 now. This was a couple of years ago. That the cardiac surgeons in the United States are doing very, very well improving outcomes in aortic valve replacement and heart valve disease. Okay, every year it gets better and better, and it's now down about 2%, even 10 years later. Besides replacement, we always try to repair valves if we can. So both the mitral valve and the aortic valve, if we can repair these valves, we should always do that. And this is just an example of the reparative option versus the replacement option. And here's a repair of the mitral valve. As you can see, we have this problem with the closure, so we put in this rigid ring, which just tightens it up. And if there's a leaflet issues, like I showed before with the cords, then we can make that all equal and symmetric. And that's a mitral valve repair. The radical and revolutionary new technology is the transcatheter heart valve revolution, which started in the middle of the 2000s. This is an example of a couple of the transcatheter aortic valves. This is a reparative device for mitral valves. and this is the new one of many transcatheter mitral valve replacements, which is still in early feasibility trials at the FDA. It is not available in the United States at this time or anywhere. But this is kind of the new cool stuff that's coming down the pike, and is really going to be the future of heart valve therapy in the future. This, along with reparative techniques, no one wants to have a valve in them if they can get repaired though. This is kind of the epiphany for me anyway. I just wanted to show you guys what a transcatheter heart valve really is like. So this is in the operating room,
wow.
And we put this through the groin, through the femoral artery, snake it around up into the chest and all the way around into the heart. This is looped inside the heart, and we have a pacemaking wire. We have a TE probe in, so we can see what we're doing not only on the X-ray but also on the echo all at the same time. So you got to be like a video guy looking at everything. I'm sure my son would be very good at this. So this is kind of what that looks like, because it's pretty revolutionary, and one has to kind of see it to kind of really feel it. This is transapical, the same concept, but through another incision. The publications, as Gary said, have been published in the New England Journal of Medicine. It's a very well studied procedure, and is going to be continuing to improve. The two approved TAVR valves are really different technologies on different platforms. This is what's called a self-expandable platform. The stent and the valve come out, and there's a continual radial force, so that's one whole way of thinking about it. And then there's the balloon expandable, like you saw in that picture, which is the other major platform, is a balloon expandable transcatheter valve. So both of them are alive and well, and probably complementary technologies. So in summary, heart valve disease is a very significant health issue. Most of the natural history result in death from heart failure. The good news is that cardiac surgeons and cardiologists with innovative industry partners have developed lots of very robust and dramatically improved treatment options. Diagnosis has improved substantially with imaging especially. There are many new and less invasive treatments being developed right now as we speak. And patient access and guideline-directed management still need continuous improvement. Thank you.
Great job.